So how do you differentiate mesothelioma from adenocarcinoma? Well, this is what the pathologists are using. And mainly sometimes they have to go to electron microscopy to make the difference. There is more microvilli in mesothelioma, more desmosome, more intermediate filament, and more glycogen. And there is absolutely no difference between pleural and peritoneal mesothelioma on a pathology examination. And that's, I think, a very important point. So this is an electron microscopy, and you can see all this filament hanging here. Okay? So these are the stains that are used to differentiate adenocarcinoma from mesothelioma. And in orange are the ones that are pretty typical of mesothelioma. Now, they're not exclusive. If they're negative, it is in favor of an adenocarcinoma. If they're positive, some adenocarcinoma will also stain with those, especially mesothelin. Okay. You can also look at serum tumor markers, and the three of them that I'm going to describe is CA125, which is usually mildly elevated, and more a witness of inflammation than a witness of cancer secretion in mesothelioma. So if you take ovarian cancer, it will be much more elevated than in a mesothelioma patient. Mesothelin is the next one, which is not yet FDA approved in this country for the diagnosis of mesothelioma, but can be obtained on a compassionate basis, but you need to register to a special IRB to be allowed to order the test. And so we can do that here, just give me a call. 84% of patients exposed to asbestos will have an increased mesothelin level in the blood, and within 1 to 5 years, 10% of those will develop mesothelioma. So it's a way to following patients that have a history of asbestos exposure. And then serum osteopontin is another one that is seen mainly with long duration of asbestos exposure and also correlated to the presence of a pleural plaque. This is not available, it's just for research. What are the systemic symptoms of patients presenting with mesothelioma? Weight loss, abdominal pain, lack of appetite, fever, night sweats. Thromboembolic disease, we describe a 30% incidence of DVT and arterial clots in patients with mesothelioma. Anemia with very low iron, which is a reflection of the chronic inflammation. And then leukocytosis, thrombocytosis, and low albumin. This is because they probably spill it in their abdominal cavity. So because this is such a rare disease, about every year or every other year, there is a panel on peritoneal mesothelioma with the expert in the country that convene at a mesothelioma meeting. And we ask them to vote on what they would do in particular clinical situation. I've been on such panels before. And so this was a panel that convened a couple of years ago. And so we voted to decide, what is the best workup for patients with peritoneal mesothelioma. This is not very scientific, but it's at least an opinion of people that see a lot of these patients. And so the consensus was that all patients should have a CAT scan of the abdomen and pelvis. Most patients would also require a CAT scan of the chest because in a lot of cases, if you have peritoneal mesothelioma, you may have also a simultaneous pleural mesothelioma and vice versa. I was very surprised to see the clinical examination was poo-pooed to a 60%. I think each patient should be examined. Ultrasound, 50%. Personally, I never order it, but it's a good way of checking for ascites. Laparoscopy in case of difficult diagnosis, and I would recommend a laparoscopy if the diagnosis cannot be made on the fluid. And then blood work, 3/4 of the physicians would recommend it. However, there was no agreement on tumor serum markers. So staging, there is no staging for peritoneal mesothelioma, again, because it's such a rare disease. So what we do, by analogy of pleural mesothelioma, where there are many staging, we're trying to derive what would be the best way to categorize patients regarding treatment outcome. And so if I go to the next slide, this is the oldest pleural mesothelioma staging. You can see that if you have peritoneal, you would be a stage 3 in this case. In the most recent classification based on TNM by the International Mesothelioma Interest Group, an abdominal peritoneal mesothelioma would be a T4 because it goes through the peritoneum, and a T4 is automatically a stage 4. So it's really hard to work with a classification that is not representative of what we see in peritoneal disease. So there has been an attempt to come up with a new staging system, and personally I divide it in 2 stages, which would be 1 to 2B, locally invasive, and you can do some regional surgery for it, or it's not operable, and then I call it extensive, just by analogy with small cell lung cancer. Those consensus panelists try to use the prognostic factors to divide the different substage. However, we have no consensus of what is a prognostic factor. And so if I look at surgical outcome and prognosis variable, the only one that everyone agrees on is that the extent of debulking surgery is a major factor in good outcome. So the more you can remove, the better the outcome. The histology subtype is common for surgical prognosis factor and for chemotherapy prognosis factor. Age and performance status are universal. You take any tumor, any younger person with a better performance status is going to do better. So this is non-specific to mesothelioma. Histology subtype, however, crossed all the different groups that looked at potential prognosis, and then pain and diagnosis was also in all those chemotherapy studies, not in the surgical study. And then there's a bunch of other potential prognostic factors, but we don't really know which one we need to use to classify patients for outcome. Okay, so what is the impact of treatment on staging? Again, this is very difficult because so few cases, very little, no randomized study in peritoneal mesothelioma, and no comparison with supportive care for peritoneal mesothelioma. So we're still debating how we should classify patients. So again, when I go back to the SEER data, this is to show you the denominator. Out of about 500,000 patients with mesothelioma, a little bit over 10% have peritoneal mesothelioma. The bulk is really in the chest. And it can also be on other organs as a primary site. So when you look at the difference between men and women for survival, women always do better. What can I do? Sorry, I'm the right sex, I guess. And then if you look at peritoneal mesothelioma versus all mesothelioma, peritoneal does also a little bit better than all mesothelioma. And I think this is related to the fact that you can expand a lot of tumor in your belly, but the chest is limited by the ribs. It's much more difficult to expand at that point. And then when you look at the effect of treatment, and this data has to be very cautious because the treatment records in the SEER data are not very accurate. You can see that patients that receive treatment do better than the ones that are untreated. So this is Mount Hood in Oregon, just to give you a breath, sorry. Now I'm going to enter the last phase of the talk on treatment of peritoneal mesothelioma. And first I'm going to speak about surgical debulking for peritoneal mesothelioma. So the current procedure that is the most practiced is peritonectomy with hyperthermic perfusion. There's still many controversies. How to identify patient, what is the best technique, does surgery really improve survival and quality of care? This is not very well known. And then despite surgery, most patients with mesothelioma will recur, and I will show you a curve in a minute. So there has been some attempt to define which patient would be the best candidate for surgery. And this is the work from Dr. Yan and Paul Sugar-Baker, looking at masses greater than 5 centimeters in the epigastric area and architecture of the small bowel. And those two characteristics would give you a bad surgical outcome. If you don't have those two characteristics, your probability of good debulking, sorry about that, is about 94%. Unfortunately, we don't have real statistics on clinical presentation for peritoneal mesothelioma. So the next slide shows you what's called the peritoneal cancer index. and this is the work of Paul Sugar-Baker, where when you divide the abdomen in 9 quarters and you look at the amount of tumor in each quarter, you just put all the numbers here and you add them. If you have a peritoneal cancer index above 13, your prognosis is much worse than if it's below 13. And this is also used for appendiceal carcinoma and other peritoneal carcinoma by surgeons. So when we look at the surgical treatment, this is again the panelists from the consensus who are voting. What are they practicing? And most of them are surgeons. So surgical cytoreduction and hyperthermic perfusion is the preferred treatment for the low malignant potential mesothelioma. For the sarcomatoid and biphasic, they prefer a more aggressive treatment with either adjuvant or neoadjuvant systemic chemotherapy. However, for the most common type, which is the epithelioid type, the opinions are very divided. So these are studies of hyperthermic perfusion after cytoreduction. You can see the number of patients here is pretty limited, except for the last study, which was a registry of surgical outcome. Age of patient is around 50, nothing to do with the 74 median average age for presentation. Complications are there, and then overall survival is much better than the standard SEER survival of 12 months, and you can see it can be tripled or even quintuple in some studies. And so the prognostic factor associated with this treatment is really the extent of cytoreduction. There are other histology subtype, no involvement of lymph node, and mitotic count were also positive in some studies. So the extent of cytoreduction, basically the limit is here. This is a good cytoreduction with the smallest tumor left behind around 2.5 millimeter. And then this is a bad cytoreduction, or difficult to resect. It's if it's more than 2.5 millimeters. And then this is the survival curve of this registry of 405 patients, and you can see that with time, people tend to relapse. Now I'm going to switch to chemotherapy, and the current standard of care for mesothelioma as a whole is a cisplatin doublet, and that's really derived from the data of pleural mesothelioma. Okay? So this is, and I'm going to show you the data with pleural mesothelioma in the beginning, and then I'll show you what we have done with peritoneal mesothelioma. So this is the list of single agent and their activity in pleural mesothelioma. And in orange are the ones that are over 20% overall response rate as single agent. And you can see that the navalbine and then the methotrexate analog qualify. However, if you know your board questions, the standard of care is cisplatin and methotrexate at this point. And both of them had around 15% remission rate as a single agent. So there has been a few randomized studies in pleural mesothelioma, and I'm going to show you the four first one. This one has not been published in full yet. So the first one was a British study looking at best supportive care or the same plus 4 courses of a combination chemotherapy or a single agent. And this was in first line, so as soon as the patient were diagnosed. Well, the results is there was no benefit over best supportive care in terms of overall survival and quality of life. In the group that received navalbine, there was a 2 months longer survival, so very minimal help. In the second study, which was also an international non-American study of 243 patients randomized to best supportive care versus the same plus Pemetrexed, there was a significant difference in tumor response and progression-free survival, but no improvement in overall survival. Best supportive care had an overall survival of about 10 months and about 9 months for the addition of Pemetrexed. But I guess if you shrink your cancer, you're going to feel better. These were the 2 studies looking at cisplatin plus either Pemetrexed. This was the Vogelzang study, and the cisplatin plus raltitrexate was a European study by Van Merbeek in pleural mesothelioma, first line, no prior chemotherapy. The doses for the American study were 75 for cisplatin, 500 for Pemetrexed, and for the European study, 80 of cisplatin and 3 grams of raltetrexate. In the study of Dr. Vogelsang, there was a lot of toxicity related to Pemetrexed until they decided to add folic acid and vitamin B12, which became a standard of care for use with Pemetrexed, and they had to remodel their statistic to come up with this number. And so this is the American study showing a 17% for cisplatin and 41% for the combination, with a 3 months difference in overall survival. And then in the European study, about the same response rate for cisplatin single agent and 24% remission rate for the combination, with survival that was similar to the one in the American study. I'm going to switch to peritoneal mesothelioma. And again, the consensus panelists voted to see what was the best treatment for patients not amenable to hyperthermic perfusion. And you can see, being surgeons, that they still send everyone to surgery. So for low malignant potential, a simple debulking surgery is enough for the panelists. For the invasive cancer, they recommend neoadjuvant systemic chemotherapy, followed by the most commonly used procedure surgically, which is cytoreduction and hyperthermic perfusion.